stent versus delayed treatment. So there have been different approaches, and this has been cited in the literature. What are the advantages of treating the cervical ICA? So you're improving antegrade flow, you're reducing the risk of thromboembolism, you're potentially facilitating mechanical thrombectomy, and you may prevent reocclusion. What's the disadvantage? You're going to have need for additional antiplatelets, the bleeding risk, length of procedure, and valid in low-income countries cost. What's the approach? You fix the carotid first, and you fix the cranial first. So I have some framing cases. The topic of the talk was to do or not to do. My answer is probably do it, but the question is how. And so here are some cases that kind of illustrate the struggles I went through when I first finished fellowship and was practicing by myself. So this is a patient with left MCA occlusion, IVTPA. Sorry, this case is a little later, but this does illustrate. So we have a tandem ICA occlusion and intracranial occlusion. The patient had received IVTPA. This patient got CTP. I looked at the CTP and I was really happy. I said, "Oh, there's no core. This is a done deal. We can be as aggressive as we want to be, right?" Famous last words. So this is the baseline angiogram. We cross-head standard technique. Usually we just take the select catheter over a wire and then just push our way through across the lesion. Treat intracranial first. In this instance, revascularized with one pass. Still feeling very good about this. So usually now we have our distal access catheter across the lesion. Usually I drop the wire and come back, do some angiograms, and it's reoccluded. Okay, we have to proceed. I usually, because I've cleared the intracranial circulation, I like to still use filters. I don't want to create more problems, send more thrombi into the intracranial circulation. So filter, angioplasty, stent. Sorry, angioplasty first. Still thinking, should I treat this? Should I not treat this? It's continuing to struggle. So we go ahead, stent, remove everything. Dyna CT scan shows this. So at this point, this patient has received IVTPA. I gave integralin loading dose, and the low dose perfusion was going on. 6 hours later in the ICU, this. So this is the second case. So this is came a little bit after this, left MCA syndrome, 24 hours later, transferred in. So they loaded him with aspirin and Plavix at the external facility going by minor stroke protocol. So the patient shows up, a little small ischemic hit here. This is our CTA. I'm seeing a distal M1 occlusion. We have an extracranial stenosis. Patient gets a CTP. Core looks very small. There's penumbra. Go to angiography, we see the occlusion. There's mesial perfusion intracranially. So same approach, cross, clear the intracranial circulation first. Come back this time. I said, okay, I have aspirin and Plavix on board already. So, okay, let's stent this. Stent it. 5 minutes later, and I always do delayed angiograms for all my patients. Start to develop thrombus. So do a Dyna CT scan, looks okay. Follow the integralin drip, and great, it's open. So we struggle in this line between your hemorrhage risk and your thrombotic risk. So what is the optimal treatment?
Did you have a full load of Plavix?
Yes, the patient was loaded. Yeah, so what's relevant to our circulation, to our population, is about a 40% resistance rate to Plavix in our population. So we've actually, even for carotid stents, we've now moved to Brilinta in a lot of our patients. So what is the evidence? We have 2 registries, and again, within 15 minutes, I cannot cover everything, but Titan and ETIS are the 2 registries which have a lot of publications and overall have shown that patients who get stented, they have a higher rate of favorable outcome and excellent outcome, so 0 to 1, compared with the no stent group. Pooled analyses have been done. Overall, the hemorrhagic complication rates are not significantly higher. Now, interestingly, from this data, there was a signal in the literature that overall hemorrhage is slightly higher, but symptomatic ICH or parenchymal hematomas are not that bad. There was some signal with regards to the level of the deficit, as well as baseline ischemia. Further analyses has shown that overall this is beneficial, even in patients who have received IV TPA. Interestingly, atherosclerosis was, I think, heavily represented. They didn't see that much benefit with dissection. And then there was a signal with regards to age. Also patients with lower deficits, the thought was this, that the stenting may not necessarily be helping, maybe these patients do well anyways. Now, of course, there's a lot of bias in this. There's a retrospective recall, there's some selection bias as well. But that's the data that we have. We have additional data now, just published in the JAMA, of a cross-sectional study, an international multi-center study, which again shows benefit in the acute stenting arm versus the non-stenting arm. Furthermore, they did not see the similar relationship, so they saw benefit even in higher age. TPA was good. They also saw benefit in patients with dissection as well. And when they looked at the best treatment, no difference in the antiplatelet regimen. Overall, there seems to be a signal in the literature about retrograde treatment, so clearing the intracranial circulation first, and then with regards to whether there's an improvement with angioplasty alone versus stenting, this has been studied as well. And overall, it appears to be that patients do better with stenting versus angioplasty, but you're constantly balancing the risk. The risk is of, if you're doing a balloon angioplasty approach alone, there's the risk of reocclusion and additional thromboembolism, versus if you're doing the stenting procedure, especially if you have IV TPA on board, your hemorrhage risk is probably going to be higher. The question is whether it's going to be a symptomatic ICH or not. So quickly, in conclusion, tandem occlusions are heterogeneous. They're commonly encountered. Revascularization of the cervical ICA is associated with better outcome. Decision making based on underlying mechanism, extent of ischemia, and your success of reperfusion. One thing that we didn't talk about, obviously these are all cross-sectional and retrospective studies. You probably, if you were successful with a higher TICI 2B or 3, you were more likely to drop a stent, right? So if you fail to reperfuse or recanalize, you're probably not going to commit that patient to a stent. So there's some inherent bias in the literature, but overall, we feel that there may be a signal in the literature that stenting helps with reperfusion. The trade-off is between the risk of acute stent thrombosis and recurrent stroke versus hemorrhagic complications. And obviously, prospective randomized controlled trials are planned. I know Picasso is one, and we have to figure out what is the optimal technique. The regimen surrounding this is still unknown. So there's so much heterogeneity amongst operators and all over the world. So I think this is yet to be determined. So I thought I would just keep it succinct, stay on schedule.
We have time for a few comments, and it's Dr. Rajat.
Yeah.
Over here, sir.
Good morning, everyone. I'm Dr. Mahesh Kumar Batra, working as an interventional cardiologist and stroke interventionist at NICD Karachi. I just have a couple of questions regarding your talk. We come across such type of a tandem lesions where ICA is totally occluded in place. Also, the MCA is totally occluded. What do you think? What should be the strategy of choice, that you should open the MCA first, then ICA, or ICA first, then MCA? Because in my point of view, or what we have read a lot, that if you are going to open the MCA first, and you are afterwards tackling the ICA, there is always a chance of thromboembolization and then reocclusion of MCA. On the other hand, if you are going toward the ICA occlusion first, then MCA, then a bit trade-off. And another thing, another question that I want to ask you about the balloon angioplasty versus stenting. Those studies have shown the stenting is better than the balloon angioplasty. But I don't think what is the rate of occlusion within the 24 hours? If you, for example, open with the balloon angioplasty and leave it for 24 hours, then come after 24 hours and do stenting. In this way, the chances of DAPT or bleeding may be reduced as compared to if you start putting a stent at the same time, and then definitely you have to give the heparins and DAPT. The chance of bleeding comparatively will be higher as you do it after 24 hours. Thank you.
Yes, those are excellent questions. I don't think that's one question. No, so while he's setting up, so the first question was with regards to
ICA versus
yes.
MCA.
So antegrade. So it depends on your setting, depends on the TPA status, what you think is safety. I prefer clearing the intracranial vault first, because that's what we know, right? Once you have a higher reperfusion of the intracranial circulation, you've already reperfused the brain, right? Time is brain. And then you work on the external later. The downside to that is that there is risk of thromboembolism. That's why I use filters. Now, I know filters add to the expense, so it depends on your situation. So if filter is not available, and if it's a complete ICAT occlusion, go ahead and you open up the carotid without a filter. You can do that. But if it's an M1 occlusion and the ACA is open, preferentially you're going to shower emboli. So that's one thing to consider. The second thing is balloon angioplasty, as I showed in the literature, stenting is superior. There is a reocclusion rate. I always do delayed angiograms. If there's significant recoil, usually in the first 30 minutes I can see that. If there's extent of ischemia is significant, if it's a large core already, I'm probably not going to commit to a stent. So it really depends. You have to tailor make it to the situation. But yes, there's a reocclusion rate. And that's why the stenting signal is there, that stenting is better than balloon angioplasty in this scenario.
One thing also, I guess, keep in mind is also compared to just a standard stenting situation, thrombosis rates are much, much higher as
Yes.
well than acute stenting. So you have to watch very carefully after the procedure, just make sure there's no thrombus developed in the stent. As you showed, the patient both we were still monitored. So I think there's another question.
Okay, first, the same comment. Usually, this is done. I know what to do first. What we do is that we pass the micrometer, and we see that if it is like a segmental occlusion, then most probably we need to open the carotid first, because you can depend on a lot of collaterals from because it might be an isolated NCA, not a terminus occlusion. So usually, if it is like that, it's much more beneficial to open the carotid first, and this is what we do usually. And usually, if we go more fast thinking than for angioplasty. This is an advantage, and you can do that now without filter. And then we go for the NCA. So we find this is more feasible and more protective, especially when you are monitoring the patient. You can see the result. Maybe most of the motor power can be regained back, but by just opening the carotid, if he has a good collateral circulation.
Yeah, so the CTA data is very valuable. So plan according to your CTA. If the ICAT is out, you don't need a filter. You might as well, you can go ahead and open the carotid up front, right? But the goal should be revascularization intracranially as quick as possible. So the stenting can come later. I usually focus on the intracranial circulation.
Generally, I feel that most people are probably going to
The studies shows the benefit to use a stent.
Yeah.
And when you analyze the baseline of these studies, all have relative good hazard.
Yes.
The question is, what do you do when you have doubt?
Exactly.
Because you move your patient using the recliner, or when your patient have a low aspect.
Yes. So then a delayed approach is probably more prudent in that scenario. And I watch after I've opened the carotid, I've done a balloon angioplasty. We watch, we'll heparinize, patient may have do antiplatelets, but I will temporize them.